Morning, everybody. Welcome to the Finance Committee. We will come to order. First item of business are there any citizens who wish to address the committee? There being none, we'll move on to item 3, which is approval of the minutes from the prior meeting. I entertain a motion. We have a motion and a second. All in favor, please say aye. Opposed? Motion passes. Sorry?
I said I'm jumping in from the beginning.
I appreciate that very much. Keep things moving. Item 4, CFO report. I've got a little ahead of myself.
I guarantee you they would be totally different. Okay, the only thing I wanted to mention to you today is again that BKD has begun field work for our external audit. They'll be in the field for approximately 4 weeks. You guys will get the full presentation at the Finance Committee in December, and then it'll be finalized at the full board meeting. So it's a fairly quick turnaround for them and for us, but I feel like it's important to go ahead and get some closure into that fiscal year. So.
Great. You want to move on into your financial report?
Yes, so this month is, as I mentioned just a second ago, I've included some different slides in your financial report than you're used to seeing because we have closed our fiscal year. So September 30th is our year end, and so all of these numbers will represent a full 12 months worth of activity. We also have, I've created some statistical trending graphs that kind of give you the last 3 years. So if it's okay with the board, I will likely not spend a whole lot of time on the monthly results. We'll focus more on the year-end results, but I'll be happy to answer any questions that you do have. We do have some year-end entries that we were aware of and have been booked in September, so it tends to skew our month-end close. I'm going to go fairly quickly through some of our volume graphs just for, again, these are for the month of September. Admissions were right on for the month, as you can see in the top left, and patient days were slightly over. Our ED visits continue to be strong from August and September. They were about 7% ahead of the budget. And you can see that our clinic visits were also strong, especially in the specialty clinic visit area. Those ended up being about 15% over budget. You can see that they typically trend down in September, so it's a combination of a really strong actual month as well as a conservative budget month that caused that 15%.
DT, do you have a question?
Quick question. Should we be concerned when the emergency visit is up, but primary care visit is down, and they're not engaged, and the urgent visit is down also as well?
You know, I see where you're going as far as the correlation, but I'm not positive that there's that tight correlation between primary care, our primary care visits, versus our emergency department visits. Yes.
DT, I'll tell you that it feels like we're just getting sicker patients in the emergency department. I think the volume we're seeing isn't ambulatory primary care level patients. It's high acuity, and I think as witnessed by hospital days and admissions and such. So it feels completely different. I would say the spike initially occurred, as we all know, with the behavioral health patients that we need to bring in. But in addition, we've just seen increased volumes and really tied around really sick patients.
Oh, I see. Because I saw that, and I saw the observation go up also as well.
Okay, good question. So in some of our other key statistics, you can see that our psych clinic visits, oops, I turned too early. Our invasive labs are up by about 6%. That's always a strong service line for us. And then I wanted to point out the increase in inpatient and outpatient surgeries. They were both positive to budget by 9% and 5% respectively. As you can see by some of the graphs, it's a busy graph, but if you just kind of focus on the overall trends year to year, and I've got another slide that will focus in on this, but we're starting to recover some of the inpatient and outpatient surgical volumes for some of the transitions that have been happening over the last 18 to 24 months with our surgical groups as they transitioned over to a claim. Psychiatric is still very strong. You can see our patient days are slightly over budget by about 3%, and our clinic visits continue to be strong. You won't see this variability next year, but just as a reminder, this year we changed some processes in different areas, and one of those was how we schedule clinic visits as patients are discharged from both the PEC as well as an inpatient status. So you can see that that has created some additional volume in our clinics. And our financial metrics, we did close the year here at about 176 days of cash available, relatively close to the last 2 years. We also have a new record low in net AR days at 44. So yeah, we got one more day off of that metric. Thank you. Yes, it is. Our connection enrollment has increased slightly by about 175 enrollees for the month. Again, we're expecting a little decrease probably coming in December and January as re-enrollment occurs for our connection supplemental population. But you can see the overall trend. You know, a year ago, we were just over 39, and now we're at 42. So strong numbers. So the next few slides are pretty much the same statistic, except it's a 3-year trend. You can see that our admission numbers have increased about 4% a year over the last 2 years. I would like to note that in 2018, we were able to add an additional 9 beds. We doubled up on our progressive care unit, so that accounted for some of that volume. And this year's volume is just throughput versus any new beds. In our emergency department, you know, in 17 to 18, we stayed about constant, but we've seen almost a 3% increase for this year. Incredibly busy. Now, if you also recall from our discussions, we were able to add an additional 12 treatment rooms that opened this September, as well as 14 treatment areas. So with that 26 capability, it's not that we expect more people to come to the ED, but we do expect our left without being seen rate to decline. So we may see, we did budget for a slight increase in 2020.
Reducing wait times as well.
Correct. There was just a slight increase. Again, not because we expected more people to come to the ED, but just because the wait times will hopefully be reduced slightly. We'll see a decline in the left without being seen rate. It wasn't a big increase. You know, with a denominator of 118,000, it's really difficult to get a large increase through that area. So a small increase is a lot of patients. You bet. Our primary care visits have kind of leveled off. If you remember, FY18 was a hiring year within a claim. We had a lot of new providers come on, and I believe that's where most of that 6% growth came from last year, and we have been able to maintain that through 19. Where you do see some pretty significant growth, again, because of some of the specialists that we've been able to hire and open up some of those schedules, have been in the specialty care area. So we've had almost just over a 5% increase in those clinic visits. Again, I mentioned surgeries. I believe we've kind of recovered to the close to the 17. We actually have exceeded in 17 for inpatient. We saw about a 10% increase from year to year, but a 5% increase over the 2 years. And then our outpatient surgeries are still on a recovery from our 17 levels, but you can see that they've increased 3% this year.
When I try and make my case for the ambulatory surgery center going up with this and not being applied to projects. Right. Because I believe the operating over here are, and the way to really decompress things is to have, move all the ambulatory surgery out of the main operating room.
Again, our psychiatric beds, you're not going to see a lot of growth as far as patient days. We do stay relatively full all year long for our psychiatric patients. And then the clinic visits, we've already talked about a bit, but almost a 20% increase over 2 years.
Karen, you make a good point there about capacity. You know, just because the numbers maybe haven't shot up a whole lot doesn't mean there's not increased demand. There's only so much of that demand that we can accommodate based on existing capacity.
Correct. And what we did see from year to year this year was a lot of throughput. We were able to manage that bed turnover better and better utilization of the patient days. Now, for our psychiatric patients, what happens with the excess demand, if they have come to our emergency department, we actually have outside providers that we partner with so that we can get them placed in another inpatient bed if medically required. So those outside beds are not included in our day count here.
I usually speak for surgery, but psychiatry is going up and up and up with all the increase in the population that will take place in the county. I think the psychiatric stuff will go way to the top of this. And then there's also the homeless and the people in jail, which most of those are probably drug related. Psychiatrically ill. So that's my 2 pleas, and I'll be quiet.
Anybody want to take a bet?
All right.
None of us are disagreeing, and Zelia's standing up and applauding, so
No,
we're all in agreement.
Well,
and
I
it's
gotta be a voice for
definite challenge.
Zelia.
Well, and Dr. Hurd as well. I mean, it is such a challenge, and, you know, I know that you all have seen it as board members, and the challenge that we have with behavioral health and what's coming into an emergency room, and then what gets diverted to a county jail, which I've always argued is the least efficient and most costly to a taxpayer, with results that are not what you want. So JPS is the epicenter for that, although it's challenging, but we need to have facilities and personnel that accommodate that.
So this statistic is from a claim. These are actually the professional encounters that their providers have seen. It's a pretty substantial increase. Remember, there's been a lot of growth going on with a claim, both in the way that we schedule patients as well as the number of providers that have been brought on board.
Sorry, this is the one that I'm struggling with the most. Because when we look at the primary care visit, we saw a decrease about 2,000 visits. But the specialty increased by 12,000, so the net is about 10,000 more visits. But it's generated 132,000 more visits, encounters.
So let me walk you through a couple of reasons why those two are not directly correlated. The acclaim encounters will include any professional touch, so all of the inpatient encounters as well as those that occur outside of our clinic visits. Some of them are related to ancillary procedures as well. And then an encounter, you may have one or more encounters per clinic visit, even from an outpatient side. So it's not exactly one-to-one, but especially when you consider that the acclaim encounters include all of the inpatient activity that happens within the main hospital.
So it's more including hospitalists and all that stuff? Or?
Yeah, well,
But these are claimed though.
Correct. There are two groups that have, and we can look at that pie chart when we pull it up. You see it's Steve's really messy pie chart that he likes. And you can see exactly what encounters and groups that we're counting in this statistic. But it includes much, much more than just those clinic visits. Okay? Did I answer your question?
Nope.
I got confused on that.
Confused, but
I am too.
so if you could say your question again, so I maybe.
What I saw was the primary care visits
Went down.
dropped down by 2,000. The specialty visit went up by 12,000, so you net out by, but we have an extra 131,500 plus more encounters that we're generating, and so that's
On the specialty side,
no total in total.
okay.
So that's I kind of have a problem following those because it does generate a lot more encounters.
So also, without having to flip through those slides right now and then back, we have behavioral health that's included, both inpatient and outpatient, in these encounters. The surgery and trauma is included here. We also have the specialties for most of the ologies: gastro, oncology, NICU, cardiology, pulmonary, orthopedics, as well as pain management. So all activity is included here, and it's not, they're counted a little bit different than on the hospital side. So a hospital, you might have one clinic visit, but the physician may actually have more than one encounter, or for one inpatient visit, there may be, 10 to 15 encounters with consultations that occur inpatient.
Do we have more specialists this year than last year? Is that right?
I don't have those numbers in front of me, but I feel certain we do as we start to fill, again, we can kind of look at what open encounter or open
Yeah, I'm just
positions
more
look
worried about
like.
utilization, that's why. It does jump up a lot more than what we should looking at.
Yes.
We do have, and I'm looking to Michael and looking to Zelia, we do have more specialists, and we brought on more in a claim. But I still see your face, and I still see your face, and I still see your face. So, and I know Michael is looking like
Michael's
so.
doing all right. He's-
Yeah, so. Yeah, come on up and sort of go through there, and let's walk through this a little bit.
Well, you're only halfway to the back today, just
I wasn't gonna make a comment about the walk, so I was told stop making comments about the walk. So the claim encounters encompass any physician encounter at any point in the network, right? So the primary care and specialty is only the outpatient. So for every single inpatient visit and every single encounter, so if I was admitted for, let's say, some diabetic issue, right? There is potentially a hospitalist encounter, there's an endocrinologist encounter, maybe there's a GI encounter. So not every visit is a one-to-one to an encounter.
Now I got you.
One visit could be 10 encounters. This is a reflection of volume that exists across the network, plus, particularly on the inpatient side, a reflection of acuity. More acute a patient, more likely they're going to have more physician encounters.
Yeah, I'm just more on the utilization.
Sure, absolutely.
Okay.
Thank you.
Now, Dorothy's not making eye contact with me, but I still see,
I think I understand what he's saying is that for all of the encounters, for any inpatient that you have, every encounter that that physician have with that patient is counted. Every different.
Every different,
encounter.
correct.
So you might have a doctor of cardiology come in, but then they might come in more than one time on that visit. So each encounter that they,
Well, it's not every specific encounter, right? So again, if I'm a cardiologist that gets consulted on a patient, right, that has been admitted, right, that global consult by that cardiologist counts as one encounter, right? But one hospital admission could result in 10 different physicians seeing that patient, and each one counts as an individual
and
encounter.
it's only counted as one time, even if they see that patient more than one time. That's what I'm
That's correct, but again, not every visit is a one-to-one to an encounter, because one visit could have 10 encounters.
so that gets you and you to understand that, because the complexity of that is true in the numbers. It doesn't address necessarily the utilization problem, and that's another specific issue, but I wanted to make sure that we had that. So I appreciate your answer, and I appreciate the complexity of the larger percentage of high acuity patients. They're going to have 10 different individuals that are going to look at them in a short period of time. And again, the utilization issue is another topic and another debate.
I think we might be using two different way of looking at it.
Okay.
He's looking at it from the encounter treatment. I'm looking at it from a building perspective, because the technical and the professional sometimes bundle into a global, and it's on one bill, and it could be counted as 2 or 3 times on your side as encounter. So that's why I'm trying to figure it out.
Right, but on an inpatient side, yes, there's a technical bill that's going to get dropped, right? But for every physician that encounters that patient, there's a professional bill that gets dropped by that individual physician. It's not a bundle, right? So the hospitalist team will drop their bill, the consults, whoever's the consult will drop their bill. So there should be a correlation that does exist between encounters, charges, number of bills that get dropped. But again, it's not always going to correlate directly to a one-to-one with a visit.
I think you can get that information more from utilization. I know where you're coming from. And that will tie back into most of the utilization information that you're asking. How many for this patient is the utilization rate for that?
Because at
Yeah.
some point, you're going to be looking at to see if it's
Right.
high you care or low you care.
Correct, and that is, as we've talked about before, trying to, look at our cost accounting system as well as some of the population health platforms that we're bringing on board, which will help enable us to both stratify patient populations and look at utilization patterns.
Thank you. Got it.
Okay, the rest of you staff in the audience can now make eye contact with me, because I'm not calling on you. Because I noticed that everybody's head went down when Michael came up, so thank you all very much.
You sure you don't want me to have a permanent, sounds like you want me to have a permanent seat.
Yeah, he can just do the financial presentation.
I got a question for you. How well would you be able to function if we had the speaker sitting over there where you couldn't make eye contact?
Which speaker?
Any,
The-
no, any.
He never makes eye contact with me anyway, so.
Yeah, no, Sharon and I don't make, no, we do. I would, it would be horrible. I would be doing this throughout the whole time. It's very helpful.
That's funny.
Okay.
So, that was really good discussion. I think we look at those statistics every month, so it's good for you guys to understand how they're interrelated.
Actually,
We also have AR days, which we've already talked about. We've seen a nice decrease, and if I would have expanded this to 3 years prior, you would still see a really nice trend line, all the way down to our current 44. Our FTEs per APD, I put this in there for Trent, and he's not here today. But this is our 3-year trend, and I do want to point out, we do have more staff. If you look at the total FTEs down here at the bottom, you can see that we've had a trend upward, but we are getting busier, and our volumes have supported that. What these numbers show up here are actual improvements based on our volume on how we're staffing. So we've gotten, we finalized the year with 5.5 FTEs per adjusted patient day. It is a complex calculation, adjusted patient day, but it's an industry standard that we all follow. So that's a good look back. So, you know, I'm really excited where we ended up the year. I feel like there needs to be music or drum roll. What a difference a year makes. But looking quickly at September, we did close the year at about 6.6 million, or the month. However, that includes a lot of our year-end entries that we had held until September. If you peeled back all those entries, we would have lost closer to $2 million this month. And the story there is really just a negative payer mix. It ebbs and flows. We had a slightly negative payer mix in August, and in September, it continued to be negative. Again, it's not a long-term trend. It's just the way that the month ended up. So I'd really like to focus on kind of where we ended the year overall. 30.6 million from operations compared to a budget of 6.8. There are a handful of items that I'm going to talk through right now that kind of come back to that 23.8 million and how we ended up the year more positively to budget. A lot of those are topside through some of our supplemental funding, and some of them are expense savings that we were able to achieve. The biggest advantage that we had this year compared to our budget was when we implemented the 340B retail program. We were very conservative in the volumes that we had assumed would go through that program, and that accounted for over $7 million of positive impact for this fiscal year. We also had a pickup in our UC this year. If you net together all of the supplemental funding, it actually ended up to be about 5.9. There are some big pickups and there are some big negatives that go through UC, DSRIP, and DISH. Our biggest pickup was UC. If you remember conversations that we had as we closed 18, we were notified that we were going to have close to a $9 or $10 million decline. HHSC went through several different formula changes, and we did not see that negative impact come through for fiscal year 19. And we closed the year about equal to where we were in 18. So from a budgetary standpoint, that was a pickup, but it actually was consistent with prior year. And we had some underages in both DISH and DSRIP, but we netted to a nice positive number. There were two, what?
Netted about
6.
Yeah, yes, 5.9.
We went over this yesterday, but I forgot my cheat sheet, so I'm
Oh,
writing
that's
this back
okay,
down.
yeah, so we did have a 5.9 million pickup. The other nice pickup that we had was some changes in our GME funding. And that is going to occur in the future. So we were able to pick up about 3.3 million that we did not budget, that we received the cash for that this year. It is budgeted for our 2020 year as well.
And to Sharon's point, and this is not an editorial comment, but I want to thank HHSC for working through that. The challenge that we have in the community needs to understand, we don't control any of that UC dollar, nor do we control the 1115 waiver. We happen to oftentimes be the pass-through of that, but there are some groups in town that if they get less money out of the 1115 waiver, they think that's the discretion of JPS. And I appreciate the compliment by which they provide us, but we don't have the ability to tell the federal government or the state government who in our community should get additional DSRIP dollars and what they should get.
We could tell them, but they wouldn't listen.
They
to
would
it.
not listen. And if they did listen, we'd look at a variety of things. But I know that sometimes when DSRIP dollars change and individual programs in town for other entities, they get frustrated because we often are the message deliverer. So when you all get phone calls from entities in town that get DSRIP dollars and say JPS has taken $200,000 out of our budget, we don't have that discretion, nor would we do that. Those are predetermined or preset, or at least last minute set by federal and state government entities, not JPS. So if you all get those calls, feel free to call me. Those other people in the community call me. You all can call me too. We just don't have that ability to choose those dollars.
And we also had a pickup from budget based on our tobacco revenue. Again, we budgeted for this conservatively. The fund only generates for us about a little over $5 million. And then the state, for the last couple of years, has used some discretionary funds to increase that pool amount. They don't have to do that, and I don't want to budget for it in case it doesn't happen. So we had a $2 million pickup in our tobacco revenue.
How much is our AR days worth?
I'm sorry,
How much is AR days worth to us?
what do you mean, an AR day
How
or?
much is-
I would,
Why are you asking that? Why are you asking that?
Why? No, I'm just, they're doing a really good job, because I want to highlight, because when you move 6 days in AR, I'm assuming each of our AR days is about 5 million. That's a $30 million cash acceleration from
let
the
me
team.
look real
doing that.
quick, I can get to it in
I'm
a
just
different
guessing,
way.
but that is a lot of movement on cash.
Okay.
No, I don't.
That they're doing a good job of collection and everything else.
I can get that number to you, but I don't have it right here.
I think it's about 4 or 5 million a day. And they move 6 days, that's a lot. Yeah, your team doing a good job there.
Thank you. I was trying to tie that back to tobacco revenue, and I was having a little bit of trouble with that. But yes, we can get you that calculation. And then the last thing that I was going to mention, you can see that we have some big underages in some of our purchase service. We were able, through some really good management, to save in some of those outside medical services and psychiatric that we had talked about earlier when I was going over the volume graphs, and as well as some thoughtful process that we did not proceed with some of our consulting or IT engagements. So we had some savings there as well. But overall, it was a really strong year. I did want to point out, when we started the budget process, this number right here was, we had projected that at about 36 million. We had a quarter which had some low volumes, especially in outpatient, as well as some negative payer mix, and that's kind of what made up the difference between our projection and where we ended the year. So, but overall, when you add our investment income with it, we closed at just over 50 million.
Let me tell you all as board members what Sharon won't say. it obviously, for an organization that has over $1 billion budget and the complexity of public hospitals, Sharon has done an incredible job at learning that process, but she's also brought in a team in Laura Thomas and Rory McCready that come from other organizations that have a huge past from trying to figure out rev cycle and trying to figure out materials management. And those two folks, along with other members, Carrie Freeman of the finance team, have really done a lot of heavy lifting, and I appreciate them. And I'm thankful for who you've brought into the team, but you don't get those numbers by having a team that isn't all working in the same direction with you as a board. So I want to thank you, and I want to thank the team members that we've brought on to this system that have brought the expertise of other organizations, and it's been very beneficial for us.
I do appreciate that. We have the ability to provide some reporting and some data to a lot of different people. And we also have the luxury of the participation of all of the operations team that can implement some of these and make some of those supply changes. So it takes everybody. When I stand up in front of our leadership team, which is managers and above, I always remind people that this happens $200, $300, $600 at a time. So there's been a lot of cost savings, a lot of utilization changes, both in processes as well as just what you use when you have an inpatient in a bed. So we appreciate everybody's effort. It takes every single person.
We've done, DT, I think, a huge amount of work in revenue cycle over the last 2 years, but I want to make a commitment to you and Dorothy and Amanda and Zim and some of the newer members of the board that connection population, and I know it's a frustrating point for y'all, it will not only be analyzed, it will be managed much more differently in the coming times. And we've set some deadlines, Dorothy, to do that, but I think we're now getting a lot better at dealing with other things, and now you can begin to take on the management far better of managing a connection population and its utilization. So I really feel that we'll get there, and I feel we've got the team to get us there.
And there's the chairman of Finance Committee, too, on
And
top
of course,
all that.
Steve's been the rock of it all.
I've been reading Dorothy's eyes all meeting long. She seems to be confused now again. Do you want to?
Mr. Bose, what's so funny?
Chairman, can we move forward? Hey, it was a great year. All those things, fantastic.
Yep, very proud.
Thank you. So this is a claim, kind of shifting gears from the medical center to a claim. Building counters for the month were about 2% under, but as we talked earlier, we were, year-to-date, we were right on target, within 0.5% from our budget plan. And you can see that up in the payer mix slide, we don't talk about that very often, but it's a little bit different from the medical center, but again, it doesn't really change a whole lot year to year. You can see that they're taking care of about 14% self-pay and about 23% of our connection eligible patients. This graph we've already kind of talked about, but it is there for your reference. You're not going to be able to read it on the screen, but I think on your portal it will show up much clearer if you have any questions on it. So for a claim, as far as a year-end close goes, there was really just one entry from the claim perspective, and we actually received a payment up in for a DSRIP project from prior year, and that was booked this month. So without that, they would have lost just a little over $1 million compared to a $2 million budgeted loss. So a strong month for a claim.
Even without that payment,
It would have been, yes, we would have exceeded and outperformed the budget. When you look at this year to date, they've actually outperformed their budget by a full $5 million. And there's two reasons mainly for that. Number one, there's an incentive payment for the management of some of these connection patients as they see them. Have they gotten certain tests? They have outperformed the metrics from prior year and from budget, so that increased their revenue from JPS on the connection population, as well as it was a new product last year. It was a new incentive plan. And we were actually able to get our reporting caught up. So there's 5 quarters that were actually recorded in fiscal year 19, and now we record that evenly on a quarterly basis. So not only did they outperform their metric, but we were able to catch up our reporting and get it year to date. So that accounts for a little over $3 million of that pickup, as well as that pain management disrupt payment of close to $1 million. So that's kind of the story there on a claim for the year. Again, very strong performance. Always my favorite slide, at least this year. I'm teaching you guys what to look at, but the year-to-date performance from a combined standpoint is positive. It's, $12.9 million. If you recall, budget 2020 was able to maintain that even with all of our inflationary impacts and new services that we have going on there. So pretty close to our budget 2020. And then if you look down at the net income, closer to a 33 million positive, which means that we can sustain ourselves in the future. Any questions? Okay, thank you.
All right, we'll move on to item B. Ms. Clark, you're still up.
Thanks. All right, that is, the next 2 items are managed care contracts for our managed care Medicaid products. The first one is for Cigna Health Spring. There's complex agreement with the URIP program where we get a premium dollar passed through HHSC on these services. So both of the next 2 items reflect the upcoming change effective 9/1 for 2 of those products that require amendment. 2 require amendment, 2 are automatically updated based on the way that they're written. So the first updated contract is for...
Both of these are Medicaid. I'm sorry to interrupt you. Are Medicaid MCO related?
They are.
Got it.
Medicaid MCOs, yes. So the first one that I am requesting approval from is for Cigna Health Spring. We're done.
Any questions for Sharon on this item? That's right, I'm spiking the ball. Any questions for Sharon? All in favor? Oh, I'm sorry, I'll entertain a motion. We have a motion. You threw me off. Do we have a motion for? Well, I get to pick who gets the motion.
Everybody here's making
We have a
a
motion by Mr. Nguyen. Do I hear a second? A second by Mr. Bose. All in favor, please say aye. Opposed? Motion passes. Thank you, Mr. Nguyen. Thank you, Mr. Bose. We get A out of, no, we get B out of the way.
Did you need to consider approval?
We need to vote on the.
Oh, did we vote on the approval of the
Oh, we
financial
need to do
statement?
that too.
Okay.
Everybody's a bossy boots today, I'm
Everybody's
telling
off
you.
of their game
All right, we
right
just approved item B
now.
on the
Correct.
signet. Now, I'm gonna go back to item A, because, so here it tells me I gotta do this. So, we're gonna go back to item 5A, which is the acceptance of the, oh, we have a motion by Dr. Weber, a second by Mr. Zimmerman. All in favor, please say aye. Opposed? Motion passes. Thank you. About like an hour and a half ago,
When
yeah.
the deal went from 5-0.
So, Ms. Clark, would you please proceed to item C, please?
I can. This is, I'm requesting approval for a similar contract, Medicaid MCO for Cook Children's Health Plan, effective 9/1.
Any questions for Ms. Clark? A motion by Mr. Powell, second by Mr. Bose. All in favor, please say aye. Opposed? Motion passes. Thank you, Sharon.
Thank you.
Wanda Peebles, item D. You're not recognized for such a motion, Mr. Nguyen. Good morning, Wanda. Welcome. This is an unruly group this morning. I apologize in advance for their behaviors.
Okay. Well, good morning. I'm here to ask your consideration for the master service agreement between Stryker and the hospital district. This is for an upgrade and standardization of our beds and stretchers across the network to include the mattresses. This new technology will have built-in bed alarms, it will have upgraded mattresses, navigation of the beds themselves and stretchers, and it will also have a tracking device on it, because we spend a lot of time every day looking for these things. So this is just to upgrade the entire fleet.
This is a big deal.
This is in our budget for 2020.
Yeah, this is a big deal, really
This
is.
is a very big deal for us, yes. Thank you.
Any questions for Wanda on this? Oh, we have a motion by Mr. Bose, second by Mr. Zimmerman. And all in favor, please say aye. Opposed? Motion passes. That was, yes, sir. Could you hit your microphone, please?
Beds that are gonna be
Replaced.
thrown away,
Yeah, move it away.
can we donate that to somebody? Or do they?
It's a great question.
I mean,
We are-
like the homeless shelter, or,
We're turning those in for credit. They're giving us a credit toward our new beds by doing that.
Okay.
So we're not just discarding them. So
All
we
right,
will get,
thank you.
and the ones that we bought in the last year, we get 100% credit back for.
Great.
So,
Yeah.
It's great.
so, the next agreement I'm asking approval for is, goes with the beds, and this is just the master service agreement, ProCare, which will perform the service, preventative maintenance. They'll have a technician on site and have a fleet of beds to change out when we need them if they're under repair during that time. They'll manage all the parts, which will eliminate us having to keep a bunch of parts and have beds down for periods of time.
Okay. Any questions for Wanda on this item? Motion by Mr. Bose, second by Dr. Schrader. All in favor, please say aye. Opposed? Motion passes. Thank you, Wanda.
Thank you.
Zelia. Is it okay, Zelia, if I start calling you Zelia Bama Ball?
Yes.
Okay.
I came to do some therapy, to group therapy with you all today.
Trust me, we need it.
We have another committee meeting after this, so I have no idea how you're going to
I'll
squeeze
be
it in.
at that one as well. I got your back. Good morning. I've got Dr. Hurd with me, so that's all I need. That's all I need. So the first contract requesting your approval is for you to consider approval of outside medical services agreement between SRP Behavioral Health of Fort Worth and Tarrant County Hospital District. That's also known as Wellbridge for those of you in the community. And this would allow us to utilize them in case we are in an overflow situation in the psych emergency center and don't have a bed for them here. And that rate of $230,000 is really a guesstimate, and it's for 2 years, not one.
Any questions for Zelia? Entertain a motion for approval. Motion by Mr. Nguyen, second by Mr. Bose. All in favor, please say aye. Opposed? Motion passes. Thank you, Zelia. Item G, please.
Yes, like for you to consider approval of non-community services professional agreement between MHMR of Tarrant County and Tarrant County Hospital District. This is for what's called AOT, which is Assisted Outpatient Treatment. And it's a partnership between MHMR, the Civil Court, and JPS. So we identify and assess and evaluate those patients that have been committed but do have a stable home environment that they can go to and follow up outpatient under commitment, and therefore not have to go to the state hospital. And there's very strict requirements in order to participate in this program, as well as oversight. And so MHMR reimburses us for the social worker that manages that program for us here at JPS. And so that's what this contract is.
Okay. Any questions for Zelia? Motion by Mr. Bose. Second by Dr. Weber. All in favor, please say aye. Opposed? Motion passes. Thank you, Zelia. Item H is being temporarily pulled from the agenda for a future meeting at the request of the county. And item I.
Yes, again, ask for you to consider approval of a contract, a countywide contract between MHMR and JPS, the Tarrant County Hospital District. The contract cost is $1.594 million. It is included in the FY20 budget. This gives MHMR funding to provide services countywide. And so we fund quite a few things, not total funding, but partial funding that allow indigent and near indigent individuals throughout the county to access various services that MHMR provides that we do not. One is the addiction services, inpatient detox treatment, which is a huge need for our community. Court liaison and aftercare services, adult mental health peer support, children's services, the Tarrant Youth Recovery Campus and Adolescent Crisis Respite Unit, and also MHMR has an excellent day treatment program for individuals with intellectual and developmental disabilities that we help fund. And then also they have a really great behavioral health crisis program that we help fund, where they respond to police officer calls in the community to try to help de-escalate and reroute individuals away from jail to another facility, or able to reroute and then back home.
Okay, any questions for Zelia? Entertain a motion. Motion by Mr. Zimmerman, second by Mr. Bose. All in favor, please say aye. Opposed? Motion passes.
Thank you, everybody.
Thank you, Bama. Kenny Carr, item J. Good morning.
I'm not David Mendenhall, but I'm actually representing him on this request, and one that is absolutely near and dear to my heart. So what is in front of you for consideration is two parts. One would be a sole source exemption, as well as the approval for the implementation of a new module within Epic called Beaker. Beaker is the module that serves the laboratory, and is a fantastic one that will allow us to more closely integrate with all of our all the laboratory results and needs throughout the entire system. The current system that we have, which is soft, it is in dire need of an upgrade, or we move to Beaker. The cost associated with the upgrade is more than what it would cost for us to move to Beaker.
Right.
And so we offer that up to you for consideration. And I'm happy to answer any questions that you have.
Any questions?
Be as good as David. I'll try, sir. I'll try.
I knew that was coming. Any other questions for Kenny? Okay, I entertain a motion. Motion by Mr. Nguyen, second by Dr. Schrader. All in favor, please say aye. Oh, wait, this is two.
There's two.
I know, I was testing you. This is a two-part motion. I don't know, go back to Mr. Nguyen. Your motion is two-part for both, and your second is for both as well. All in favor, please say aye. Opposed? Motion passes. Thank you, Kenny.
Thank y'all very much.
Scott, anything from council?
Good morning, Mr. Chairman. There were 41 contracts under $500,000 in September 2019. Those are all uploaded to your board portal for review.
Okay, any questions for Mr. Cummings? All right, we have no items for close, so I'm going to move right on to item 9A, and we need to convene in full board mode. Mr. Chairman of the board, would you like to handle the gavel from this point?
You're doing very fine.
You want me to be your surrogate for this one?
Yeah.
It's pretty quick.
All right.
So Kenny, I guess there's not a lot to describe here, but if you want to just give us a quick overview of item 9A.
Yes, and I appreciate everybody doing this. We would like to, we're in need of replacement of our current CTs within the ER.
Okay. And this is a budgeted item, and it's all,
Yes.
there's everything there. So any questions for Kenny on this?
I think the agreement wasn't discussed executive, to bring it
Yeah.
straight to this meeting to expedite this, we need it.
Correct.
Discussion with Robert.
Yes, sir.
Yes, sir.
Thank you.
So therefore, if there's no additional discussion, we'd entertain a motion.
I'll make, second?
All in favor, say aye.
Aye.
Carries, thank you.
Excellent.
Kenny, thank you.
Appreciate everybody.
Thanks for expediting that. I know we,
Okay. I think the board and the committee are adjourned.
Zelia, you got an hour between